existing in the middle of the lush and prosperous Sundanese area, which is rich of various culture and natural magnificence. Becoming milestone in educating the nation, building persons to be society servants and nation founders. Universitas Pajajaran, or UNPAD, was born due to the initiation of West Java leaders and government support to establish a higher education institution with various disciplines. Launched by President Sukarno on September 11th, 1957, today, UNPAD has a large number of institutional achievements. Such as status improvement as the incorporated higher education with A accreditation. This achievement is in line with the commitment of all policymakers in order to accomplish the vision and mission of UNPAD to be excellent university in conducting a world-class education that is able to support the nation's competitiveness through a quality learning process and innovative research. The representative learning facilities and strategic campus in the center of Bandung City, Bandung Regency, and higher education zone in Jatinangor, Sumedang, make UNPAD as an excellent university in conducting education, research, and community services. Through its best programs enabling to fulfill the needs of society, nowadays, UNPAD has 16 faculties and 1 postgraduate school, totally consisting of 152 study programs. Faculty of Law, Faculty of Economics and Business, Faculty of Medicine, Faculty of Mathematics and Natural Science, Faculty of Agriculture, Faculty of Dentistry, Faculty of Social and Political Sciences, Faculty of Arts, Faculty of Psychology, Faculty of Animal Husbandry, Faculty of Communication, Faculty of Nursing, Faculty of Fishery and Marine, Faculty of Agricultural Industry Engineering, Faculty of Pharmacy, Faculty of Geological Engineering, Postgraduate School. Realizing the importance of learning process, curriculum and learning method are continuously developed in order to adjust the dynamics of stakeholders' needs. Nowadays, UNPAD has used student-centered learning method. That is, learning method focuses on students as the base to actively involve in developing knowledge, skills, attitude and behavior with competence-based curriculum. Supported with professional faculty members and staffs, UNPAD is capable of generating competitive and characterizing grade weights. Until now, it has registered 10,000 of students from all over Indonesia and hundreds of international students studying in Universitas Pajajaran. To optimize the education and learning processes, UNPAD is supported with various representative supporting facilities, such as library, basic science service center, language center, e-learning, teaching hospital, and dental hospital. In addition, UNPAD is also equipped with student dormitory, health facility, sport facility, campus transportation, banking, hall, and entrepreneurship facility. Such various facilities are supported with the utilizing of information technology. Besides supporting the academics quality, Universitas Pajajaran also fully supports the activity of student character building through some student unit. As a part of society, Universitas Pajajaran absolutely realizes that its function is limited not only in teaching, but also social and cultural aspects. Some social activities, society empowering, and research implementation have been conducted to give real benefits for all society. Universitas Pajajaran, straightening and developing together with society, from West Java, for Indonesia, to the world, through SDGs.
Are you interested in learning about cleft lip and palate with experts from around the world? And you can learn this for free while gaining 3 credits. Come join our online course in collaboration with Faculty of Dentistry, Universitas Pajajaran, and Sponsoring.
Greetings from Transcendence 2021, massive open online course in cleft lip and palate, held by the Faculty of Dentistry, Universitas Pajajaran, collaborating with Smile Train, and YPP-CBL has been going on for a few days. My name is Josephina. I am a preclinical dental student from the Faculty of Dentistry, Universitas Pajajaran, Indonesia, and I will be the master of ceremony of today's live discussion. I see that we came from different countries, so I think it is appropriate to say good morning, good afternoon, and good evening to everyone here. Also, greetings to our expert today, Dr. Paa Ekow Hoyte-Williams from Komfo Anokye Teaching Hospital, Ghana. Thank you for being here, Doc. It's been an honor to all of us, and we really appreciate your presence here. How are you, Doc?
Doing very well. Thank you so much for the opportunity. It's a great honor for me as well to participate in this live discussion. Thank you
so much, Doc. Okay, and greetings to all of the participants. Thank you for participating in this course, and thank you for attending this live discussion session. So, Doctor, today is our third live discussion for this week. In the previous discussion, we have discussed about presurgical nasoalveolar molding and nasoalveolar molding for unilateral and bilateral cleft. Today, we will discuss about cleft rhinoplasty, nose revision surgery. And we also have our moderator today, Dr. Dian Maifara, oral maxillofacial surgery specialist, and she is one of my lecturers in Faculty of Dentistry, Universitas Pajajaran. How do you feel, Doc?
Hello, Dr. Paa Ekow Hoyte-Williams. It's very great to have you today with us.
Thank you, madam. Thank you. I really appreciate it.
Okay. Thank you. And I would like to explain about this live discussion. So it will be separated into 2 sessions. In the first session, the professor will be answering the questions that have been filled out by the participant on the MOOC platform. The questions will be presented on the screen. The participants have already watched the lecture video about the related topic, which is cleft rhinoplasty nose revision surgery. So they have seen your lecture though. Even though I think not everyone can make it into this live discussion, but don't worry, I'm sure that all other 300 participants that have registered to our courses have watched your lecture video as well. Next, in the second session, the participants will have the opportunity to ask the questions directly to the speaker through the Zoom chat, and they will write down the questions, their name, and where they are coming from. Or the participant can also unmute their microphone and ask directly to the expert in the second session. Now, I would like to give the spotlight to our moderator, Dr. Dian, and Dr. Paa Ekow Hoyte-Williams as our speaker today. Dr. Dian, you may start the first session and lead today's live discussion. Thank you so much. Now we are moving on to the first session.
Okay, thank you, Doctor. Well, hello, Dr. Paa Ekow Hoyte-Williams. What a great lecture you gave us. And your topic is about the nose revision surgery. And so many questions comes up. Without further ado, we go to the first question. The first question is come from Farista Atsari from Pajajaran University. And she asked about when is the best time to do nose revision surgery? Does the premaxillary position, okay, maybe the first question, you can answer the first question. When is the best time to do nose revision surgery? Please, Dr. Paa Ekow Hoyte-Williams.
Thank you very much, ma'am. Okay, when it comes to nose revision, usually the timelines for cleft nose rhinoplasty is clearly stated when we have the primary, that is at the same time when you're doing the cleft, at the intermediate, usually the preschool stage, then the definitive rhinoplasty. So for revision, I think the best time would be at the definitive time when the bone growth has ceased. So in ladies, probably by 16, 17 years, in men, 17, 18 years, this would be a good time to do your revision with more permanent lasting results without much change in bone growth. That would probably alter the results you get. So this would be a good time, I'll suggest, when growth has ceased, around 16 years, 17 or 18 years. Now, thank you.
Okay, and does the premaxillary position correction at the, sorry, maybe we can go to the first question. Sorry for the committee, please, we go back to the first question. Okay, the second question is, does the premaxillary position correction at the pre-surgical nasopharyngeal molding stage provide significant convenience at the rhinoplasty stage? What do you think, doctor?
Yes, it does. I mean, certainly, if you look at some of the slides I presented, if you have a very wide defect, flattened elan-naci, flared so wide, certainly correction will provide some challenge as compared to the one that, you have very good macular apposition. That will certainly be easier. However, it's been found in the long term that the long-term results is not affected so much with this, but at the time of repair, if you have a good apposition of the premaxillary position, repair is certainly more easier for you.
And do you always use the pre-surgical nasopharyngeal molding for every case or only a certain case?
Okay, so in my practice here in Ghana, we hardly use pre-nasopharyngeal molding. The best we probably would do is the lip taping. where we use a tape to oppose the lids. We don't use pre-nasal alveolar molding devices here in my practice. So I don't use it, and I don't have much experience apart from doing my fellowship, where I saw it was usually something they do routinely. And in that practice, in where I was in Changan, they had a lot of benefits because it lengthens the columella, it brings the maxillary processes closer together, it improves the nasal dome, but I don't use them. And so far, I would not say the results are comparable, but the results are very good as well, just with the taping.
Okay, maybe for the next question is, which method is the best to release the fibrofatty attachment of the skin to the cartilaginous framework?
Okay, so because in my presentation, I was talking about the semi-open rhinoplasty, it is what I will recommend. The recommendation is based on one, if you consider the closed-step rhinoplasty, you do a blind dissection of the fibrofatty attachments to the skin of the cartilaginous framework. So you're just feeling and putting your dissection scissors or tenotomy under and just blindly releasing. But in the semi-open, even though you do not raise the whole tip of the nose, you have the privilege of having some direct vision. You can be more precise in the dissection. So I will recommend the semi-open tip rhinoplasty as a very convenient and advantageous method to use.
Okay, what do you ever deal with patients that have a keloid problem? Would you still recommend a semi-open rhinoplasty or not?
Great. So keloid is very common in our population here. And in my experience with cleft lip, usually keloids are not extremely common at the extremes of ages. So in infants and in older people, it's usually common in the middle ages, adolescents onwards. In our cleft repair, we don't often, we probably will get hypertrophic scars, which improve over time. But in quite a huge number of cleft surgeries I have participated in, I have observed from my training up to now, I haven't really seen the occurrence of a keloid. And in the technique as described by Professor Philip Chan of Changa Memorial Institute, they also have problems with scars as well in that their population, the Oriental population. They also can get keloids, but in his experience, he never talked about keloids as well. So keloids can happen. I will not rule that out, but we don't have that experience, and it's not very common in the babies.
Yeah. Okay, so you still recommend the semi-open rhinoplasty?
Yes.
Yeah, okay. And the next question is, what are the complications for the cleft rhinoplasty?
Okay. Well, I mean, during the surgery, I mean, intraoperatively, probably you could make a buttonholes in the skin as well. Probably you will not get the correction you have. It could gape when you bring the LNSs close together, because in this case, we try to narrow it more than the normal side. You could have some scars, hypertrophic scars, but hypertrophic scars over the period would improve with time. Sometimes if you don't have very good hemostasis, you could have a hematoma collection beneath the skin. If you don't put sutures in there to narrow the space you have created. These are probably the common things I have seen. Yes.
In your recommendation technique is semi-open rhinoplasty, you make an incision in non-cleft site, right? Yeah.
Yes.
And would it affect the aesthetic of the non-cleft site, or what do you think? Would it affect the non-cleft site, and what about the aesthetic later?
Okay, so this technique over the years, it's been practiced over 30 years in various reviews, various publications, in review of the results, assessment of the results over the years. There has been no documentation of the aesthetics of the non-cleft site being affected. You know, in this incision will be used in someone going for a cosmetic rhinoplasty as well. You know, it's the same incision that will be used for someone who's probably going for a cosmetic rhinoplasty. And with the Tajima incision on the cleft side, Tajima documented that he's not seen any contractures. The reverse U incision does not provide any, does not cause any contractures by its nature. You know, so for my experience, what I've observed and what I have read and studied, I have seen no documentation of the aesthetics of the non-cleft site being affected.
What about a large dissection of submucous, and would it affect the midfacial growth?
Okay, great. Thank you very much. You know, Macomb and Slayer also, in their reviews of rhinoplasties over the period, documented clearly that the rhinoplasty does not affect the mid-face growth. Usually, the palate repair and the scars that comes with the palate repair has been what has been documented to cause the mid-face hypoplasty or mid-face retardation of the growth in cleft patients. Apart from the fact that some people believe that the mid-face growth is an inherent property of the cleft disease process. So these are all school of thoughts. But in terms of the nose rhinoplasty, over the years, all the reviews they have done compared it, they have seen no effect on the mid-face growth.
It's very interesting, Doctor. Well, we go to next question. Next question is there any consideration in choosing the right rhinoplasty methods for every patient? What do you think, Doctor?
Great, that's a good question. I think that if you don't have very severe disparity in the nose, the disparity or the difference is very minimal, probably you could just do the the closed tip rhinoplasty in that patient. That avoids all the incisions I talked about. But if there's significant disparity, and if you really want to reposition the alar dome, properly, then the open tip rhinoplasty comes in, where you can release all the fibrofatty tissue and also release the alar from the attachment of the maxilla, so that it can allow you to reform. You can reform the cartilage properly. So one, if the disparity is not very significant, I mean, I'll be okay to practice the closed tip rhinoplasty. If there's significant disparity, I'll certainly go for the semi-open rhinoplasty. Yeah.
Okay, so when the patient have the allergen not so bad, so you can choose the closed technique, sure. Right?
Yes.
Yeah. Okay, for the next question is there any way to minimize the need of the cleft patients to undergo nasal revision surgery? What do you think, doctor?
Yes, there is. By standard, cleft rhinoplasty has probably been done in 3 times in the cleft patient. Now, when the team in Changan started doing this semi-open tip rhinoplasty, they have obviated the need for the preschool rhinoplasty. So they found the results in that from infancy to be sustainable and good enough that there's no need for the preschool or the intermediate rhinoplasty. And then most of their clients will come only for definitive rhinoplasty. So this method has reduced the number of rhinoplasties you can do. In a population where the nose is extremely important in aesthetics, in some populations, the nose is it's very important for every population. But in some, they just can't tolerate deformities in the nose. It will be difficult to prevent that because you did this rhinoplasty in the primary stage, in the infant. There's going to be growth, there's going to be changes, retractions, remodeling here and there. So definitely there may be the need for the definitive rhinoplasty. But this practice, like I said, has taken out the need for one of the surgeries, that is the intermediate rhinoplasty. So it is just only the primary rhinoplasty, and they do the definitive rhinoplasty after using this method for a long time. So probably already the surgery has minimized the need to undergo nasal revision surgeries by one of the surgeries. Is that clear, or do I need to explain it again?
Okay. So do you always do the rhinoplasty for every unilateral cleft?
Yes. Rhinoplasty, we have adopted it as a component of the primary cleft lip repair. So once we do a primary cleft lip repair, rhinoplasty is done. In my here, I'm the first person to propagate the semi-open rhinoplasty. What I used to do and what most people do here is the closed tip rhinoplasty. When I came back, I practiced the semi-open rhinoplasty, and I have seen the results, which is really long-lasting. In this method, it is not only about releasing the cartilage and allowing it to shape whilst you close your defect. You purposely shape it using sutures, interdermal sutures. So that some way, somehow raises the cartilages and holds it together. So doing that, I noticed that, when I compared it to my previous results, and there's a significant change, and the results being longer lasting. So one, primary nose repair or rhinoplasty is done in every cleft patient here. And it's not everybody who does the semi-open rhinoplasty. Most people will do the closed tip rhinoplasty. But with my incorporation of the semi-open rhinoplasty, I have seen better and longer lasting results.
Thank you, doctor. Okay, we have another question. If a patient has had rhinoplasty related to cleft while they were young and feels unsatisfied later in life, is it possible to do rhinoplasty again while they're older?
Yes, sure. It's possible and it's recommended, as long as it brings down their confidence and makes them feel good to get into people and to socialize. So it is possible to do a definitive rhinoplasty or to do another revision, as we call it.
would it will the surgery become more difficult because the patient have had first rhinoplasty?
Yeah, expected to be difficult, more difficult, but it is not overly difficult. You still get your planes to dissect clearly. Naturally, there will be some scar formation. There will be some difficulty, but it is not overly difficult, and it is not a challenge, or it is not something that would prevent anyone from continuing or doing the revision or secondary rhinoplasties.
Okay. And the next question is, semi-open rhinoplasty has a lot of benefits compared to closed method. Is there any situation where it is not possible to do semi-open rhinoplasty?
Okay, that's a good one. Well, of course, maybe if the nose is not very healthy, maybe the skin is too thin, or you think that making an incision will cause more damage, then certainly I will not recommend you to do an open rhinoplasty or to do any rhinoplasty for that matter. You know, one advantage I propagated is that in the semi-open rhinoplasty, once you have made the incision and you really dissect the cartilages, you have some direct vision of the cartilage, and you are more precise in the release of the fibrofatty tissues, as compared to the blunt one that you cannot see. You just put your finger on it, feeling it, and passing your scissors, and then releasing the tissues. So you're using just your skill to feel, and that's we believe is a bit more traumatic compared to the one done under direct vision, where you can see and be more cautious, you know. But is there any situation that would make it impossible? I mean, in medicine, we never say never. There could always be a situation, and I think that would be up to the surgeon's judgment and experience to say, no, this won't be a good nose to attempt any form of rhinoplasty.
Well, have you ever dealt with that kind of situation where you cannot do the semi-open rhinoplasty, or you cannot do the rhinoplasty?
No, I have not had that experience.
Okay, so you always do the rhinoplasty when you repair the cleft lip?
Yes, I'd always do a form of, either open or closed.
Okay, and asking again about what age is the most ideal for rhinoplasty. Maybe you can answer it one more time, doctor, please.
Great. Currently, the recommendation is to do rhinoplasty at the time of the primary cleft lip repair. It's been shown convincingly and overwhelmingly that the outcomes are better and the aesthetics, and at times it improves the typical facial appearance of the cleft patient that we call the stigmata of the cleft lip repair. So when the repair is done at the time of the lip repair, we describe that as a primary rhinoplasty. Now, this may be either using the closed method or the semi-open method, or as others have done, the open method. After this one, usually at the preschool age, there is still some deformity as the child is about to start school. The child is not comfortable, is not happy. Friends will start teasing the child. So it is another stage where you can also improve the nose, the nose. So another rhinoplasty can be done at that preschool stage. As the child grows and matures, there will be some deformation along the way, contraction, retraction here and there. So at a point when all bony growth has ceased and the nose is at its definitive size, which won't change again, you can then do what is described as the definitive rhinoplasty. So these are the times where rhinoplasties are considered in the cleft child or the cleft patient.
Okay.
By the time, what is the most ideal time for rhinoplasty? I will recommend primary rhinoplasty. Very few patients in my population come for definitive rhinoplasty, very few, you know. And if you do a good primary rhinoplasty, you could further reduce your patients who would come for other form for rhinoplasty as they grow. So the ideal time, one, primary rhinoplasty is a good time. And if the patient wants a revision, then I recommend that the next ideal time would be when all bone growth has ceased, so the definitive rhinoplasty.
Have you ever deal with failure when you do the primary rhinoplasty? And what do you do?
Failure, right?
Yes.
Okay.
Have you ever deal with failure of your primary rhinoplasty?
Okay, so failure here probably would be one when you have a dehiscence of the lip, maybe the outcome wasn't good enough, or the nose still is flared. Well, if that should happen, I would allow it to heal and I would wait. I would not intervene immediately. Yes, if I didn't get the result I wanted, or there's maybe the lip is dehisced, so the nose is, the LS are flared again, would allow everything to heal. And probably I will wait for the intermediate phase around 6-7 years and consider to redo it. I won't do it if that is what you mean by failure.
How long will you wait until you do the revision?
Okay, so I'm assuming that failure means I didn't get the expected outcome. Is that correct?
Yes. And maybe that you mentioned before the dehiscence, and then the nose still looks flat and the outcome is very bad.
Yeah, in the child, I mean, I know this would be a problem for the mother or the parents.
Yeah.
The child will not really feel this. I will counsel the mothers, and I probably wait till the child is at the preschool age to redo it. I will not be in a rush to correct it immediately. I will wait for a considerable time. So I'll wait for the preschool age before doing it.
Okay. Thank you so much, doctor. So next question. Is there any possibility which cause rhinitis after rhinoplasty in cleft patients? Is there any possibility? What do you think, doctor?
Okay, so which cause rhinitis? That's inflammation. Usually when we say rhinitis, I'll be thinking like a cold but if you think about infection or inflammation, of course, there could always be infection after surgery. There always could be infection after surgery. It's not very common. I mean, in a well-optimized patient, this doesn't happen very often. I've had no experience where I'd have infection of the nose. No, not, I haven't had that experience, but it can happen. What can prevent this? What are the possibilities? I think that the patient must be well optimized for surgery, well-nourished patient, good nutrition, good HP. The patient should be well, not sick, not have any underlying infection. You know, the cleft repair shouldn't be done as an emergency. So the patient should be well optimized, and this would reduce any possibilities for rhinitis in these patients. However, if rhinitis means just a runny nose, like a viral infection, which I think it is, then it's usually they're usually self-limiting and would resolve over a short period of time.
Okay, and you recommend the semi-open rhinoplasty. Do you only release the subfatty tissue or all the muscles around the nose?
No, so the dissection is up to the limit of the lower lateral cartilage, where it joins the mid-lateral cartilages. So the dissection is not the whole nose. Mm-hmm. It's up to the level at the end that the caudal extent of the lower lateral cartilage. And also if there's any attachment of the lower lateral cartilage to the maxilla, it is released to allow it to allow you to reshape it. So we do not release all the muscles of the nose, no. It's just a fiber fatty tissue over the lower lateral cartilage. Nothing more than that.
Yeah, thank you very much, doctor. Do we have another question?
I think that's the last question on this screen, but I have another question. May I ask the question, though?
Okay, please, doctor, you can ask the question.
Okay, thank you. So I want to ask, in white cleft patient, the defect of nasal deformity is more severe. Is there any way to minimize the scars after rhinoplasty?
Okay, great. Usually, what people have done and have published in the PRS is, and in my experience elsewhere, they used Botox injection after cleft lip repair, and they have a number of publications that PRS about this, and that has shown significant improvement of the scars. I don't use Botox. Certainly, I would have a wider scar, but usually, what I do in the first week is I still put a long tape across the lip during the healing phase of the wound in the first 5 days or up to 1 week, which bunches up the muscles so that there's no stretch on the muscles after repair, so that the wound, the opposed edges are very comfortable together and it heals without any tension. I found this to be helpful, but this is just anecdotal. I have not published any results to show the long-term outcome of that, but I found this to be quite helpful. So after my repair, I put a long tape. I don't keep it for just 1 or 2 days. I keep it for about a week. It does not interfere with feeding. Of course, it will be dirty with secretions and all of that. But when I take it off, it's fine, and it allows the wounds to heal the first week without any tension. And I think that could be helpful. But those who have given Botox, and in Changa, we gave Botox after every surgery. It's been published and it's well documented that it improves the scar.
is it okay to use Botox on baby?
Yes, so they have done this over a long period. And like I said, they have documented the results in the PRs, in plastic surgery. And it is well documented with very good results.
Okay, I see that. Thank you very much, Doc, for the answer.
Well, do we have another question? It's a very interesting discussion we have today with Dr. Paa Ekow Hoyte-Williams.
Okay.
Thank you.
I think that's the last question, Doc. Thank you very much. Now, before we end this live discussion, I think we can take a picture first. For the committee, can stop share screen first. Okay, thank you very much. Now we are going to do the photo session. I will take the screenshot. So I will count. For the participant who haven't opened their camera, please open your camera because we are about to take a picture.
Please send me a copy.
Okay, I will send it. Maybe you can send, I will send it to your email. Is that okay?
Excellent.
Okay, I will send it to your email. Okay, I think we will start the screenshot right now. Okay, 1, 2, 3. Okay, another one. 1, 2, 3. Okay, thank you very much. It was a great opportunity for all of us to hear valuable knowledge from Dr. Paa Ekow Hoyte-Williams on this special occasion. In this hard time of pandemic, we can still find the bright sides and learn another new thing in cleft lip and palate. Keep stay motivated, pace yourself to learn, and continue completing the courses because we have a lot of amazing speakers coming. My name is Josephina. On behalf of the Faculty of Dentistry, Universitas Pajajaran Indonesia, and the entire committee would like to thank Dr. Paa Ekow Hoyte-Williams as a speaker, Dr. Dian Maifara as moderator, and to all participants who have joined this live discussion. Thank you so much and goodbye. See you in the next live discussion.